forward later afterwards. Welcome everyone. Dr. Afshan, thank you for making time. And Dr. Tareem, who's in the background. We can't see because of this situation, but at least we can hear you. And thank you, Dr. Kiran. We can hear you, but obviously cannot see you. These are all the webinar setting in which by default you have to come in like this. So look, I would like to just quickly run through the program. We're just going to do some trial sessions. And I'm going to start with the introduction. And if you need to ask questions, just raise your hand. And Dr. Afshan, you might be able to just, hover around where the hand is raised and you can mute them so they can ask questions if need be.
Sure.
So I'll just start with the first. Now, everybody can see the screen?
Yes.
Yeah. Good. At least this part we got it right. So look, welcome to the AMC clinical course. We're starting our course today. And I thought it'd be a good opportunity to just take some time and explain to you what we're going to do over the next 12 weeks. And Dr. Afshan and Dr. Tareem have been with us for the last couple of courses, and it's been brilliant. And we've had some good, successful result. Thank you for Dr. Afshan, who's completely revamped the entire content of the course, and Dr. Tareem for being very diligent. Lots of thank yous, and it's amazing. Dr. Faryal and Dr. Farwa were there as well in the previous course. So thanks to them as well for putting on the hard work. So we're going to talk about the sessions, which are in the morning and evening. Morning, they are Sydney time. So not 7, it's actually 10 to 1. And evening session is 7 p.m. to 10 p.m. There's only Monday and Wednesday. So it makes it easy for both us and yourself to make yourself available. And if you don't find the time to attend those live sessions, you can have the videos available on the portal. So AMC portal is the main thing. That will be the hub of our communication. All of the sessions which are conducted on Monday and Wednesday, they will be uploaded onto the portal within about 24 hours. So we've got a pretty good tech support. So surely it shouldn't be a problem. And those Monday and Wednesday session have been repeatedly being done for the previous courses. You can always catch up on the videos of previously conducted session as well. So as I said, that the people who have joined our course have already gotten access to the portal. This is for your own personal use only. If you share the password and everything, the system will lock you out, and then it'll be difficult to get entry. And please don't contact me after the system's locked you out. So just make sure that you are using it fairly and not sharing the password. We have sent instructions to all the people who have joined our courses, and I've seen that all of them have logged on with the material. As I said, the videos are uploaded after every session, and they should be available within 24 hours. That is Tuesday for Monday session and Thursday for the Wednesday session, for those of you who have missed out. Now, I'd just like to obviously talk a little bit about why AMC Clinical is important from the job perspective. It saves time. I always maintain that once you've passed the AMC MCQ, you are belonging to a large cohort of group of people who are applying for jobs. And especially if you've got career gaps. Recently, we've seen lots of people who have had large career gaps. Previously, it used to be the things that people who've got career gaps of more than 10 years need to do AMC Clinical to be able to apply more broadly, for the hospital to shortlist them, because there's certain hospital which would not just shortlist you if you've not passed clinical. So people who have got gaps, have passed clinical, have done the recency, make themselves available to all those hospitals. So from the point of view of broadness and diversity of application, AMC Clinical does provide that. It saves time. And why do I say that? Look, whichever training program you want to join, whether it's a GP training program, which most of the doctors would join, whether it's a physician's training program, or surgical training program, or radiology, or anesthesia, or ED training program, or even psychiatry training program, you need a full registration. So one of the pathways to gain full registration is AMC Clinical. The other pathway is WBA. We all know the WBA waiting lists are like blown out of proportion. They are looking 12 months, 18 months, up to 24 months in the regional hospital. So waiting for that placement to happen for you, it's just going to be very difficult to gain all those positions in a timely way. So by passing the AMC Clinical, then at least you've got that thing out of the way. And when you get the job offer, at least that job will start counting towards the general registration requirement experience from day one. Gaps, we've talked about that previously. It used to be the large gaps, the people who counted, and now it's even the people with smaller gaps, like maybe 3 years or more or less even. It always puts you in a better position once you've got AMC Clinical in terms of applying for jobs. And yes, sometimes you may have a very unique situation. I'm not talking about unis, but I'm talking about more general perspective that if you've got a gap and if you pass the clinical, then doing the recency, it does give you an edge over the rest of the people who have not done AMC Clinical. Universal job applications we apply for. You can apply for jobs in Darwin, Western Australia, Tasmania, in Sydney. Liverpool Hospital has given IMGs their first jobs in Australia just on the basis of AMC Clinical. So be sure that you apply quite broadly. Liverpool Hospital would not even shortlist you if you've not done AMC Clinical. Darwin is another one of those examples. They tend to prefer the candidates who pass AMC Clinical. Now, as a rule of thumb, I don't know if you've heard about it, that it says often for gaining a mastery of any skill, and I think AMC Clinical is a skill, you need at least thousands hours of preparation or thousands hours worth of experience. Now, what does 1,000 hour looks like? It looks like, 4 hours per day, constantly every day of the week, every day of the month, for the next 8 months or 10 months. Nobody's got that level of time. And that is a completely new skill. Now, AMC Clinical, you've already done your OSCEs as being medical students. You've already passed your AMC MCQ. So with a little bit of certainty, I can say that those 1,000 hours are actually not 1,000, they're 500 hours. So then it becomes more doable with 4 months of preparation time, 4 months, 5 months. By the time you get the date, it would be probably 5 months or 6 months. So this is based on that you're spending at least 3.5 to 4 hours every day in proactive study, meaning that you are engaging yourself. It's not the thing that you can memorize. Yes, certain aspects towards the memories, okay, but it's more about, interacting and talking, which makes you help pass this exam. So this is the glimpses of, plus the other thing which I want to talk about, that we also give CPD certificates. So if you are applying for registration after the job application, then CPD is going to work for you. This is how the portal looks like. You can see all the topics are nicely laid out on the left-hand column. You click on the topic, the scenario opens, you can play the video, and then down below would be a complete details of the scenario that you can look into. All right, moving on. We will have 6 months access to that, and we can further extend this access. As I said, that videos from AM and PM sessions are loaded. Dr. Afshan, just remind me, was it loaded on the same portal, or was it loaded on a different portal? As in, because our portal is
Everything
now.
is aligned in same thing year-wise. So it was like 23. We took it in January. The second one was
Okay.
the last one, July, August, and
Yeah.
this one. So it's lined up in a yearly and monthly basis. Yeah.
So we'll do the same, that we will do the September course and all the AM and PM videos under the September. Wonderful. Further extension, we've talked about portal saves time. And I say that with a very good amount of confidence and conviction. This is not a book-based exam. It is a practice-based exam. Most of the things that you need to learn, you have already learned them. Yes, you need to finesse a certain core concepts. You can do them. And all of that information is available in portal. Dr. Afsha has completely redone the cases now, and most of the crucial elements required for these cases to pass have already been in there. So you can pretty much take almost 90 to 95% of things required to pass the exam through just course only and interaction. Rest of the bits and bobs would be shared with you through the email, through the WhatsApp group that we've got, and plus also there are available things on the portal. How do you prepare for sessions? As everybody did for the last few years, you go to the portal, you have a look at the video. The cases are nicely laid out. Now, the cases in the portal are old. We have completely redone the course. Well, Dr. Afshan has very kindly redone the course. So now the cases are different, but it gives you a flavor of the topics. So when you're reading those topics through the portal, then you're preparing. And it's a good exercise that you've prepared for that topic and now you're applying for it. It will be easier for you to attempt that. Next up, you watch the video, you listen to the feedback that I've given, Dr. Afshan given, Dr. Tehreem's given, and other tutors given. So you make your critical points, and then you read the notes and guidelines again. And we do about 8 cases, role plays, and so 8 cases, 8 feedbacks. If there are 8 course candidates, they will do it. If they're less, they will do it twice. If they're more, they will get their chance alternatively, but everybody will get a chance. Never have we ever had a complaint that I don't get enough chance from the course. And obviously you get a feedback and your active participation. We can almost certainly say that who are the people who are going to pass from day one. The people who are actively engaging and participating should be able to pass this exam. We do trial exams, mini trial exams at the end. Now, people often say that, look, my exam is booked out quite later. Don't worry about it. It's not a full trial exam. It's just to highlight that you finished the course, which are the areas which are your strong point, which are the areas which are your weak points, how can you optimize further till your exam date. So please utilize this opportunity of doing a trial exams, approach your teacher and book in a trial exam. I think, Dr. Aksham, what was your experience like with the trial exam last time?
Well, I would say so. Like, we usually take trial exams within 15 days of finishing the course. So it's like, yes, some of the candidates are prepared, some of them are not prepared. But when we do this mini trial exam, we do it 1:1, and we give the personal feedbacks and everything. That is really helpful for them. So now initially they are going through the course. Okay, everything is new and this and that. Once they take a mini trial exam, they come to know what are the drawbacks and where are they lacking. And many of the people, like many of the candidates previously have said, okay, now we know where we have to work hard and what we have to learn. So yeah, mini trial is helping you in that way. Okay. Obviously, if you have prepared already, or you're going for a second attempt, so you have already given an attempt and you're giving up the second attempt, you must be a little bit here and there prepared, like 60-80%, like for those who are beginners. That is again definitely going to give you a proper review, like what to do. Yeah.
All right. Okay. That's good. Thank you very much. And general feedback we've talked about. Okay, so how to access the portal? I think every instruction has been sent in the email. I don't think that we're getting any more emails of complaints that we're not able to access the portal. Everybody's been able to access. What are the session times? As I said, it's 10 a.m. to 1 p.m. and 7 p.m. to 10 p.m. So that's a morning session, a.m. and p.m., which is an evening session, only on Monday and Wednesday. And they are Sydney, Melbourne time. So whatever time zone you are, we have had people attending the course from New Zealand and Sri Lanka and Bangladesh and what other country? Or Middle East, quite a lot of you, and then some South American countries. So find your time zone and do the course. Don't miss out a session. The content of the course is exactly the same in between the course, so you're not missing out. No, you don't have to register for trial exam. No, you'll get all the videos if you can't attend the session. We've talked about that, and you'll be given a CPD certificate at the end of the course. And that's it. So in terms, I said aim high, even though there's a reduction in certain number of standard of passing the station, but you should still aim to pass all the stations. Give yourself time, plenty of time. I'd say 16 weeks, but core time in terms of active preparation, last 12 weeks leading up to the exams are very, very important. Book-wise, it's not an exam which is book-based, but at least having these sort of books for referencing, which is AMC Clinical Book of Handbook of Clinical Assessment, JMERTA, is important. And Dr. Afsham would probably further highlight if there's any other reading resources. Would you like to highlight for?
Yeah, so well, yes, John Murdoch and Handbook, again, Handbook is very old book, but still it is useful for some cases. John Murdoch, again, a few of the updates and logic from John Murdoch is again very helpful. Again, for physical examination, I would recommend Telly O'Connor. That is again very helpful. There are nowadays physical examination are coming more like disease based. So like they'll give you an explanation of pericarditis, and you have to give an explanation of physical examination of pericarditis. So what are the points? What are the positive points we're looking for pericarditis? It's very nicely given in Telly O'Connor. Likewise for other cases as well, other diseases as well. So yeah, Telly O'Connor for physical examination. Again, there are other notes like Karen Marwan. There are those notes are also very helpful. So go through that as well.
Wonderful. Let's do that. And yes, dedicate some time. It is a hard, hard study, and needs a bit of discipline. 4 hours of preparation time with your work and family might not be achievable. But look, some days you're good, some days are bad. The good thing about the course is that the amount of time that you have to spend singularly or studying alone, 4 hours could be cut in almost half by learning from others, interacting with others, or doing the case yourself. You cut your time. So interact, interact, and interact. Yeah, as I said, plenty of material out there in our portal in terms of course and videos, and they're all organized. So you don't have to keep a track that, look, I was doing session 12, case 13. It's all marked. It is bookmarked automatically. So wherever you left, you can start from there. Okay, so we'll do a couple of cases, and then we'll take any questions. I think raising hands. We've gone through that. Okay, yeah, most of the people did that. So we'll start with that. Dr. Afshan, what I'll do, I'll stop my slide and I'll get you to do. In the meantime, while you're setting up, I'll take a few questions.
Yep.
I think there might be some hands which are raised. Oh, hang on, I've raised my hand for some reason. This is something which is going to be very interesting. Hang on. Okay. So there's a hand raised by someone. Okay. Okay. There we go. Allowed to talk. Yes. All right. So I've just allowed to talk for. Okay. And Dr. Kiran, I've also asked to unmute. So Dr. Yusuf is asking a question.
So can you hear me right now, right?
I can hear you now very well. Yes. Thank you.
Okay. Hope you're doing good, guys. Hope you're doing
Sorry
good,
about
Dr.
this
Swan.
technical glitches. We're learning as we go along.
So you can hear me clearly, so I can speak actually.
Yeah.
Okay.
Yes.
The thing is, first of all, I'm sorry if my question is far away from what you just explained about everything about AMC Clinical. I tried to book a meeting one-on-one with you since like 2 weeks, but there is no time until 25 November. So I
Okay.
tried to engage with you in this Zoom meeting so I can ask this question. I'm one of those who have been graduated, take the license in their home country, and finish the internship here. And now I'm planning to do the AMC MCQs, and from that on, I'm gonna do the AMC clinical because this is what I see is the clearest pathway and much more logical one. So if you finish those, it's much easier for you to get a job. So my question is, does the internship year here in my home country helps? Or let's say if I work here more than after I finish my internship here for like half a year or a year, that helps to pass the AMC clinical one? Because as I understood, the AMC MCQs
Yeah.
is based on clinical knowledge.
Yeah, always any clinical experience helps, Dr. Yusuf. So internships, RMO experience, any experience is almost certainly going to help.
Oh, and what about the next course for the AMC MCQ one? When it's gonna
Uh,
start? How can I
yeah, so
register
I
with
think the
you?
next course is going to be in February for MCQ. You can certainly join that one.
And oh, so like the exam is as I know that the exam has done every single month, but January and September not included, right?
Yeah,
December and January.
December,
Oh,
January. Yes.
December and January. So
Yeah.
the next course is gonna be in
Yeah.
February. So
Yeah.
I have to wait till February, right?
Yeah.
Yeah, so you will be waiting till they announce for the opening of dates, which could be probably in November. So
Okay.
they will open the slot like maybe it's February, March, April, 3 months or 4 months or 2 months. It depends how they're opening now. So it totally depends upon that. So you have to keep an eye with on your portal, AMC portal.
Okay, good. Because I'm planning to sign in with you guys and be with you through through all this process because I
Yep.
see
If you are planning for like February, March, April for the initial months, so this time, like the next from next week, we are starting this course. That will be really helpful for you. So think about that.
Yeah.
29, right? I also booked the Zoom meeting that you're doing in 29, right?
Okay. All right. Sure. We'll catch up there then
Mhm.
and take it in with more detail. Thank you very
Oh,
much.
I'm sorry again if my question was away from what we just
Oh, that's
explained
all
and what
good.
you talk about, but I just wanted to know. Thank you so much. We'll
No
appreciate
problem.
that.
Thank you. Cheers. All right. Okay, Dr. Afshan, you can start now, I guess, in the interest of time.
Yep, sure. Okay, good. So I'll be showing you the slide, and anyone who is interested in doing the case. And Dr. Rizwan, how would I know who wants to do it?
Yeah, I think it's going to be very difficult. So how
Mhm.
about we just take
Just
it
pick
through the
one,
case?
pick a
Yeah,
name.
yeah.
Okay.
Just go through the case, I guess.
Yeah.
Because with the webinar way, it's going to be very difficult unless and until somebody's pick up their hands, and they can probably do the case, or they want to do the case. So allowed to talk, Dr. Sneha, do you want to do the case, or what's the go here? Dr. Sneha. Let me just have a look. Ask to unmute.
Mm.
So guys, just keep your questions relevant to the course. Dr.
Hello.
Sneha. Yes, Dr. Sneha, would you
Sir,
like?
first of all, I'm very happy for talking to you because I've been trying since through all the social media platforms. Dr. Rizwan sir, I'm very happy to talk to you.
Yeah, thank you very much. It's a pleasure. We're just talking about the course right now, not any personal career guidance,
Yeah,
unfortunately. So
yeah.
if your question is related to the course, that's fine. Otherwise, I might have to just move on with the case because we got close to 134 people here who are here for AMC Clinical.
Oh, sir, actually, I have a doubt and also would like to go through the case. So if asking
I
doubt
think
would be,
No, I think I'll just refrain from making any comments about the career guidance right now. Please send me an
yeah,
email,
yeah.
info at emergency focus, and we'll take it from there.
Yeah, sir, I'll go through the case then.
Okay, perfect. Thank you.
So
So
Dr.
let's just
Sneha?
start, Dr. Afshan. Let's just
Okay.
start the scenario, I guess.
Okay. So Dr. Sneha, can you see the slide? Hello?
Hello, hello.
Yeah.
Ma'am, can you hear me?
I can hear you, Dr. Sneha. Can you see the slide?
Yeah, ma'am. Yeah,
Okay.
I'm seeing the slide.
Okay, so I'll just give you 1 minute to go through the case, to the scenario and to the task, and then we'll do a role play for 8 minutes. Okay?
Yeah, yeah. Hello.
Yeah.
Yeah, ma'am. I've just gone through the case.
Okay, I'll let you know when your 1 minute is done. Yeah.
Yeah, sure.
Okay.
Start here.
Okay. Yes, Dr. Sneha, your 8
Yeah.
minute time starts now. Start.
Okay. So the first task is being taking history for 5 minutes from the mother, right?
Yeah.
So I would like to ask what exactly happened. What is the history of the presenting illness? And what's the time of happening and where exactly has happened and what's the way the boy has collided with his friend as per the question.
Okay, Dr. Sneha, the questions are all relevant. You need to do a role play with me with that.
Okay, ma'am, sure.
You're the person who's taking exam, and Dr. Afshan is the examiner, and you've got a time which starts now.
I'm your role player now. Okay, so I'm the mother of this 11-year-old boy. Start with your first task.
Hello, ma'am. So would you like to tell me what exactly happened and how the boy was hit and collided? Can you please give me the exact way of happening?
Well, doctor, thank you for seeing me. My name is Emma, and this is my son, John. And it was like, doctor, as it's already been stated that my boy was playing football, and all of a sudden he collided with his friend while playing football.
Okay. So, can you mention me, is there any history of hitting hard object on the ground, anything?
Well, no, doctor. He didn't hit the ground or so. He just collided with the other one of his friend, and they both collided head by head.
Okay. On the way of getting to hospital, is he able to talk? Is he able to walk? Is he able to interact with you?
Yes, doctor.
Okay. Does he have any history of the same falling and getting collided in any past time?
You mean has he been collided before?
Yeah, yeah.
No, no, doctor. This is the first time.
This is the first time. Okay. Is he having any history of congenital defects that you'd like to mention?
What does that mean, doctor?
Any birth defects at the time of birth?
Well, no, doctor. Since birth, he has always been a healthy boy.
Okay. Um, his vaccinations and immunization and his nutritious histories, everything is normal, or anything abnormal you'd like to mention here?
No, doctor. His immunization is up to date, and I am not worried about his nutrition.
Okay. And is he having any problem in defecating and urinating since the collision and the incident happened? Any voluntary micturition or defecation on the way?
No, doctor.
Okay. So that's it, ma'am. I've tried my level best.
That's okay. So, the mother is asking you what is wrong with his son. So, what diagnosis or what provision diagnosis can you explain her?
The boy is conscious and oriented, as mentioned, and the vitals are normal. So I would definitely take a look at the vitals, and then I would say go for a CT head or for the investigation. And while after seeing the CT, and I would definitely say that everything is normal. If there is no abnormality or something like that,
Okay.
that would be my point of view.
Okay. So your point is valid, but although this is not how we do it, like during the exam or during the role play. Anyways, this was your first try, so good try anyway.
Thank
See
you.
what is happening here for everyone. There's a boy, 11-year-old boy, who has come to you to the emergency department where you are an HMO or an intern. It could be of any designation. And she's worried now because the boy collided with the other boy, and that is why he is here. Now, colliding with another boy it's not very, like we have kids, if they collide, we just don't rush to emergency department. That is what you want to know now, why this female has come with the son to the emergency department and what has happened to him. It has already been stated in the scenario itself that the boy is conscious and oriented and the vitals are normal. That means what now, that you have to assume that the boy is absolutely normal. Why? Because if it's an online exam, for those who are going for online exam, you cannot communicate with the examiner. He's going to be there, but his video and audio will be off. He is not going to communicate with you. So you have to assume everything, and also you have to make sure that the patient whosoever is coming is vitally stable. If not, then you're making him vitally stable. Okay? But here it's been given that he is normal. That means you have to proceed with your history. Now, asking the history. So what are the history points you want to ask from the mother, so to come to a diagnosis and for the immediate management? Okay? So first, yes, you have to make sure she is a mother. Okay, you have to make sure that her boy is safe and sound with you. Like, first you have to assure her that yes, Emma, need to ask her first how can you address her, what is your name, what is the boy's name. Okay, and you introduce yourself as well. Okay, so hello, my name is Dr. Afsha. I'm one of the doctors here. May I know your name, please, or how may I address you and your boy? Then she will open up, yes, doctor, my name is Emma and this is my son John. I don't know what happened to John. Can you tell me what's wrong with him? She will be all, very anxious and worried and everything, obviously. So now you have to make her calm and reassure her that everything is going to be normal, because you just need a few information in that regards. Okay, that is how you will open up with a pediatric case, especially. While asking the history, Emma, now can you tell me, Emma, don't worry that your boy is now feeling well. We have checked his vitals, that is his blood pressure and temperature. He's all doing well. So do you mind me asking a few questions in that regards? Now she'll be all calm and now she will answer everything. Otherwise, she won't. Okay, that is how they are asked to. That is how the examiners told them not to open up until you reassure or calm her. Okay. Now asking the questions. What happened? When did it happen? What happened immediately? Because you want to know when, because it's an boy is brought to an emergency department. You want to know what is the severity or what is the urgency of this case. Okay, so how long it happened? Did it happen yesterday? Did it happen 16 hours ago? Did it happen like half an hour ago? That is how you will assess the severity and the emergency of this case. Yeah. Now, once, like, since when did it happen? Yeah. What did he do after that? What did the boy, what happened to the boy when he collided? Did he fainted? Did he lost his consciousness? So that is what it is. First is loss of consciousness, which is very important. What are the red flags for this boy now? One is loss of consciousness. Okay, while he was unconscious, did you notice any jerky movements? Now we want to know, because of this collision, did he had any seizures while he was unconscious? Okay, now you want to know how long was he unconscious for? Was it like few seconds, few minutes? When did he gain his consciousness, and how did he gain his consciousness? So like, did you had to do something? Did you have to wake him up or shake him, throw water on him, something like that? How did he wake up? Once when he did wake up, was he complaining of anything? Was he complaining that he couldn't see properly, couldn't hear properly? Was he having any headache? Was he having any nausea or vomiting? These are all red flags for this boy now. Okay, so that is what will happen. Okay, has it happened for the first time? Which was very good, which is one of the question. Yeah. Now, when you are asking questions to this layman female, you need to be very layman. You cannot use medical jargons like defecation, micturition, burning micturition, and so you have to, in AMC clinical, if you want to pass, you have to go very layman. Although some of you must be working and using the medical words, and obviously people are understanding here, but for the exam, say go layman. Okay. Yeah. So yes, that. And now you want to know whether this has happened before as well. Does this boy has any past medical condition, any allergies? We do have a mnemonic for that, like BINDS. First is birth, immunization, nutrition, and development. Yes, we'll ask that. What I'll do is I'll run through the slides so that will give you a better explanation. So yeah, the time and mechanism of injury. They have said they have collided. That is very well given, but in some cases they might not even give that. Okay, so you need to ask what happened and how was the injury happen, which you did somewhere here and there. Okay. Okay, there are some situations which we will do in our course about the cases of non-accidental injury, where now the accident, the injury is not explaining the mechanism as of what mother is trying to say. Okay, we'll do that later, but that is not needed here. So loss of consciousness, if yes, then how long? What was the duration? Nausea, vomiting. Because these are all going to give you a red flag and also an indication whether this boy need a CT scan on it. Okay, so yes, any other injuries? Obviously, he has collided. So she might say, doctor, he has got a bump over his right head or right side of head or left side or wherever he had got collision. Okay, any bleeding tendency, because he might be bleeding inside. We don't know that. Any past injury like seizures, headache, amnesia. Okay, any seizures at this point. That is what all are red flags which you need to ask. Okay, primary survey. Yeah. So when they have said that the boy is vitally stable, you do not need to do primary survey, but here and there you need to ask the mother whether the boy is stable or not. So like after when he gained his consciousness, was he playing? Was he altogether normal, or did he had any stupor state? Okay, again, that is going to give you something. Yes, so when it comes to the diagnosis, you might say because of this collision, he's got the bump and that is concussion. For any of the cases, any of the head injury cases, once the patient is in emergency department, you need to do a full neurological examination. You need to admit that patient. You need to admit why, because now you're going to observe him for at least 24 hours. So the criteria for him to being admitted is like for staying there in the hospital for 24 hours, where everyone is going to observe him, including a specialist if needed. And if the specialist, if you or the specialist have got this red flags or the indication to CT scan, yes, definitely you'll go for CT scan. Otherwise, you will just leave that on the specialist, whether he wants to do it or not. So what are the indication for a neuroimaging? Maybe it's CT scan. Any signs of basal skull fracture, focal local deficit. So yes, you're going to ask, is the boy by any chance unable to move his hand or feet? Okay, hands or legs. Any suspicious of skull fracture? So that is when we are going to do the examination and you're going to ask for questions in that regards. GCS, or yes, once if the boy is not fully conscious, you will assess the GCS. That is another question we'll do later. Any seizures that was noted. So in positive history of these things, you will go for neuroimaging immediately. You might not even wait for the specialist. Yes, you will say that you are an HMO, you are a junior doctor, you're going to call upon your senior and or maybe the specialist, and we are considering to do a CT scan. Okay, so basically what you're going to do is you're going to admit this child for 24 hours. If he's all good, he does not have any red flags, you can discharge him by explaining about the red flags to the mother, and then you can discharge her. Although if you see anything like persisting headache, irritation, confusion, drowsiness, seizures, loss of consciousness, obviously you're going to the senior is going to review. Okay.
Wonderful. Thank you very much. I'd just like to make a few points. That look, the scenario was about an 11-year-old boy who's been brought to emergency department by his mother. You're working as an HMO in the hospital, and the boy was playing football and collided with his friend. The boy is conscious and oriented, and the vitals are normal. I've just reproduced the scenario for the sake of people who've just joined it. Take history for 5 minutes from mother, and that's what we've done, Dr. Afshan, that look, the scenarios are very much timed, and after 5 minutes, the scenario should be moving on to the other. So the history, the whole idea is to, as Dr. Afshan was saying, to put the classification whether this child is a mild head injury, moderate head injury, or severe head injury. That is the key aspects that I'd be focusing on. Now, in terms of past medical history, allergies, immunizations, and bind, they are relevant, but less so as opposed to the head injury relevancing. So I would be starting off with, look, what happened exactly? How did he collide? Did he hit head? Any signs of basal skull fracture, like as in any blood coming from the ears, any clear fluid being coming from the ears? Did he lose consciousness? Did he have any seizures, any neck pain? These are very important questions to ask, which would highlight towards the point of a red flag, placing the child into head injury. Or the other point would be that the child has been constantly vomiting since the head injury, or has got any signs of basal skull fracture, or has got an ongoing headache. So if he's got those red flag signs, then the child would immediately need a CT brain. Okay. But if it's like the child was a bit amnesic to the event, now he's completely and slowly and gradually returning to his normal state of, how he normally behaves, then that's fine. Then he could be in a phase of a concussion. Okay. Now, the other thing which we commonly see in our own emergency department, the child would have had an injury, he would have had a vomit, and he would have had a headache. Now, how do you decide that this child is mild, like an amnesia or concussion type of scenario, or is this vomiting is more going to become something more sinister? That's where the observation comes in. You observe them for a duration of time, overnight sometimes, if there are ongoing concerning signs, give them analgesia and not image them. And obviously, if the circumstances change, the headache is not resolving, the child is constantly vomiting, or the child is continuously being amnesic to the event, then you scan them. Now, explaining the immediate management, I completely agree with Dr. Afshan that you have to explain it to a mother. When it says mother, have to explain it to the mother. And sometimes, the easiest way of explaining is to just relive the story. Now, as you said, Mom, that he was running, trying to grab a football, and he hit his head, collided with his friend. And when the heads collide, there's skull underneath, and he may have had quite a significant amount of trauma. And it's quite natural after having that level of significant amount of trauma to, fall down. Sometimes people lose consciousness or pass out, as we say. And that's pretty much what's happened. Now, these facts would have been already established by this history-taking moment in the first 5 minutes. But then you also reassure as you go along that, look, based on the history and all of the things that we provided, it appears that, this 11-year-old boy is not significantly unwell. He had initial amnesia, he had some headache, he had some initial vomiting, but now, as you said, he's returning back to normal. So from that point of view, I think we need to just observe him. And if things change, we need to image him. Now, you have to remember something, that whenever you decide to neuroimage any child, you need a parental consent. And for the parental consent, you have to take a consent that, look, how much this radiation is going to cause an exposure towards development of a cancer. So they say for every 1,000 CT scans that you do, you induce one child with a cancer. That's just a roughly ballpark figure. So you have to understand that more CT scans you request, the more you're heading towards that way. So it has to be rationalized. You can't just do and request a CT scan just because you feel that every head injury needs to be scanned. It has to be rationalized, that for concerning sign, we can do a thing called a CT scan, a big donut scan, which will look inside the brain and make sure there's no bleeding. So really labeling it out. And at the end of the day, you have to summarize that this is what happened. This is what my assessment says. This is how we're going to manage him in terms of observation. And if things improve, he can go home. If things do not improve, we may have to do a CT scan for which he needs consent. Then ask them if they've got any question. That is so pivotal and important. Okay. And then obviously any information that they need in terms of leaflets and guidelines, you can provide that. We'll jump on to the next case, and I'll get Dr. Tahreem to do the next case. And if somebody wants to do that case, they can raise up their hand, or
I don't know who is user. He or she did request for the previous case as well. So I
okay.
think we go with him.
Okay,
or her.
okay. User,
Dr.
okay.
Dr. Islam, you can remove me from co-host and put Tahreem as co-host for this case.
All right. Okay. Yes,
I'll
that's
share the
Yeah.
screen anyway.
that's
Dr. Rizwan put Dr. Kiran as the co-host for this one. She has specifically asked for this
all
one.
right. Okay. So, okay. So Dr. Kiran is here, and I will. Oh, hang on. Promote to panelist. I'll promote her to panelist. I think this is all very new for me. And ask to unmute. Dr. Kiran, can you ask to unmute? I'm saying, Dr. Kiran, you there?
Dr. Kiran, yeah.
Yes, I'm here. You have to allow me to open my video.
Yep. That's fine. Now we got you. All right. So wonderful.
Am I visible?
Yes, you're visible. Thank you, Dr. Kiran. Thank you. And sorry about all this technological glitches.
Yes.
So
It's
you've got
new
the
for me
accent.
as well, Dr. Usman. Yes,
Okay.
yes, I have.
So we'll move on. I think
just-
Dr. Afshan, can you just remove your slides so Dr. Kiran can just share her slides?
Do you want me to flip the same slide?
Oh yeah, that's fun. That would be excellent. Yes. So let's just do that. Actually, I figured out a way to even Dr.
All
bring
right.
Dr. Tahreem into the picture.
Yes, you can add as many co-panelists as you want.
Panelist, yeah. That just realized. Okay. Yes. Now, Dr. Tahreem, I'll ask you to unmute and make a co-host. Okay, you can start now, Dr. Kiran.
Okay, so do I have a volunteer to be the doctor, or should I just go
Yeah,
with
there
the
was a
case?
person called user who
Yeah, I
wanted to,
think we have
or we got Dr. Zara here who's raised her hand as well, so we can get her perhaps. We got another 10
So
minutes.
allow
to
any one of them to speak.
Yeah. So let me go and allow. So we've got Dr. Zara. Dr. Zara will allow you to talk and you can interact in this. Talking permitted. Dr. Zara, how are you? Can you hear me now?
Yes, I can hear you.
Wonderful. Okay, you can start the case. I'm sorry about all this, but I'm slowly and
Hello,
gradually
Dr.
getting a
Zara.
hang of it.
Hi, doctor.
Hello, Dr. Zara. Hi. So just to save time, I'm just giving you a heads up on how to do this. So whenever the screen flashes, the questions on your screen, you have got 2 minutes to realize and to understand and to make a organization on what you're going to do in the next 8 minutes, right? So those 2 minutes are very crucial. First, read the tasks. First, read the tasks and then go to the STEM. So it will save you a lot of time. So in case the task is you have to take a history for 4 minutes. Now, history questions comes in 2-3 formats. One is when there is a short history, a relevant history. So you cannot be asking about STAGMA and everything in these cases. You have to take a relevant history which is relevant to the case provided. Then exactly at 4 minutes, physical examination card will flash, and whatever history you have taken, you have to correlate with the physical examination card, and that will give you a diagnosis. Okay. So then you'll have to explain either the mother or the examiner the diagnosis with reasons, and you have to strike off all the differential diagnoses here as well. So whenever you read the STEM, you should immediately make a list of differentials in your head that I'm going to ask about this, and I'm going to strike off this. Usually the AMC STEMs are long and they give you a pretty precise picture of what you're dealing with. You will never be in a dilemma that, oh, what is this? You will always have a clear picture of what is going to happen in the next 8 minutes, right? So when you have a differential list, you know what to ask, but you have to go through a certain approach. Now, Dr. Rizwan has a very nice slide that you'll see in your lectures. It has a good organizational structure in which, like, you first of all introduce yourself, then you check for hemodynamic stability, then you reassure and you ask for concerns, like what is the concern of the patient? No, and then you reassure them again. The communication, clinical exam is all about communication. Okay, the more you connect with the patient, the better they will give you the history, and the better you will be able to explain to them the diagnosis and the differentials later on. Whatever questions you've asked in history, only those differentials you will be talking about while explaining. If you have not asked something in history, you cannot keep it as a differential when you are going to explain to the mother, right? So I'm timing you. Your 1 minute starts now. Go through the task and then I can role play with you. I'll be your patient and you'll be my doctor.
Okay.
Right, we'll get Dr. Zahra to start, please.
Okay. Hello, my name is Dr. Zahra. I'm one of the doctors at the emergency department. Can I please know your name and your child's name?
Hello, Dr. Zahra. I'm Kiran, and I'm so worried. My child just had a fit, and I'm so worried about him. Oh my God, I just don't know what's happening. I'm so nervous. I'm so panicked. I just brought him just immediately to this department, and he was just playing, and suddenly, all of a sudden, he just started, jerking like this, and I got so panicked. Just help me, doctor.
Oh, I understand, Kiran. I can understand that you're going through a tough time right now and you're worried about your child, but I can assure you that as you're here now, me and the team of doctors at the hospital are going to try our best to make your child feel better soon. Could you please tell me more about what exactly happened to your child?
Oh, yes, doctor. So he was just playing with his, toys, and I was just doing some work in the kitchen, and I saw him. He was lying flat, and all his hands and legs were shaking like this, and it was so sudden, and he's just 1 year old, doctor, and he just then kind of fell unconscious, and then I just rushed to the hospital.
Oh, that must be quite stressful for you, Kiran. I understand that. So I need to make sure that your son is stable at the moment. So for that, I need to check his pulse, blood pressure, temperature, respiratory rate, and oxygen saturation so that I can move forward with some more questions. Is that okay with you?
Yes, doctor. Thank you, doctor.
Okay, Kiran, you said that your son was lying flat and he started to have some jerky movements of his body. How long ago did that happen?
It happened about half an hour ago, doctor.
Okay, is it for the first time this happened?
Yes, doctor.
Okay, so what do you mean by having jerky movements? Could you try to explain to me a bit more?
It was like his hands and legs were shaking rapidly.
Okay, so for how long did this happen?
I think, doctor, it lasted for about 30 seconds, half a minute just.
Okay, okay. So did he lose any consciousness after that?
Yes, doctor, he felt unconscious. That is why I brought him to the hospital immediately.
Okay, so is he conscious now? Did he
Yes.
gain? Okay, okay. So was he having so did he lose and did he bite his tongue during the seizure?
No, doctor.
Okay, so do you think that he passed urine or passed stool during the seizures?
No, doctor.
Did he have any weakness in any part of the body after that, or any problem with his vision or his speech?
No, doctor. After that, he seems fine.
Okay, that's all right. So, do you think that he might be having fever or any rash anywhere on his body?
No, doctor, not that I have noticed.
Any nausea or vomiting?
No, doctor.
Any diarrhea or constipation lately?
No, doctor.
So, how would you describe his generalized health? Any loss of weight or loss of appetite or anything significant happened lately?
No, doctor. Mike is a healthy child and no problems.
Did he have any trauma, any fall at school or while playing? Did he, sorry, not at school, I know he's just 1 year old, maybe at childcare, or maybe he get hurt while playing?
Yeah.
No, doctor. No, doctor. He's at home and I have plenty support at home and he's taken good care by his grandparents as well as his father and me.
Okay, so have you noticed that there
It's
is
your
any
4 minutes
change?
up, and this is your perfect card.
Oh,
That's okay.
okay.
We'll
So the
just tell
perfect,
Fifi.
yeah, the
We
perfect
don't have PC, but the PC is normal. The physical examination is
Okay.
all normal. You can go.
Okay, Kiran, right now, so Kiran, I have the P is normal. Okay, so
Yes.
most likely what I'm thinking is he just had a seizure. He doesn't have fever, doesn't have anything positive. I don't know the diagnosis. What should I explain? But I want to examine him and yeah, so most there could be many reasons why he must be having the seizures. Most commonly in this age group, the seizures could be related to high temperature, body temperature, or having a fever. There could be other reasons for the seizure as well. For example, I don't want to scare you, but it could be something nasty inside the brain and nasty growth. It could be some electrolyte imbalance that can be because of excessive vomiting and diarrhea. It can also be related to some heart diseases, like congenital heart diseases, and it can also be related to a disease called epilepsy. But right now, I'm not sure why exactly the seizure might have happened. I need to run some tests to find out the exact cause of the seizure, and also want to call my senior specialist from the emergency who can come and have a look and guide me further regarding the test. Meanwhile, I am going to make sure that your child is stable. I am going to monitor his vitals, his blood pressure, pulse, temperature, and respiratory rate. I'm also going to check his sugar levels, because one of the reasons of having seizure in this age group can be low sugar levels as well. And that's it. I'm just going to
No, that's
observe him.
that one thing
It's
before I would like to say before Dr. Kiran gives you feedback, that you speak very eloquently. It's very good, very clear. Maybe it's your mic, but I think it's a bit more than that. It's
Yeah, I've
I
got
think
it
you
for
speak.
$400. I think it's
It's
my mic.
no, it's definitely you speak very clearly and you speak. I'm able to understand you, and you have got a very calm and reassuring tone to your voice, which is definitely going to help you in this exam. So
Thank
I
you.
think 10 out of 10 marks in terms of communication. Obviously, you need to layer it up with a bit more organization. this is a
Yeah.
child, and you've completely highlighted it could be a febrile convulsion, it could be a non-febrile convulsion, it could be something more nasty but doesn't want to scare you, it could be something brewing in the brain, and electrolytes and all that kind of jazz. So that's very good layout and an explanation from that point of view. I'll get Dr. Kiran to sort of give you a feedback quickly before we move on to Dr.
Yeah.
Kiran.
Thank you, doctor.
So Dr. Zara, it was a wonderful attempt. You finished in 6 minutes. Your communication skills, as Dr. Rizwan pointed out, are excellent. You started off well. You took care of the hemodynamic stability. Then you reassured me pretty nicely, but you took 1 minute and 27 seconds to do that. You have to be a bit quicker. You
Okay.
cannot waste 1.5 minutes in just your opening statement. So you have to find out an opening statement for yourself and ratify it over and over and over again so that you can use it on every station. So you just say it with proper empathy, just like you did. Just be a little bit more quicker. Try to wrap it up within 45 seconds. That's it. Okay.
Okay.
Then after that,
Thank you, doctor.
you should ask the child's name. It's better if you talk to the patient with her name, as well as whenever you talk about the child, you take his name as well. That will give you a better connection with the role player. Okay, and it will seem like a actual doctor to patient talk. Like whenever you see patients, you ask their name and then you explain to them things. So you cannot keep saying your son, your son, your son. You have to have a name. Okay.
Okay.
And after that, in the relevant history, see, J. Motag says that you always have to rule out red flags first. So you gave a differential of brain tumor in the end, but you did not ask any question pertaining to the brain tumor in the history. So the red flags in case of a seizure would be injury, persistent headache, any bleeding disorder, any fever, any sort of infection. It can be anywhere. So you have to ask infection questions from the sinuses, from oral cavity, from the chest, from the abdomen. So nausea, vomiting, diarrhea, cough, running nose, any earaches, rashes, fever you ask. So you have to rule out all the infections. After that, you have to take a medicine history. Is the child on any drugs? Is the child on any medications so far? Is he suffering from any chronic illness? The child is 1 year old. And then pertaining to the brain tumor problem, you have to ask any loss of weight, loss of appetite, any lumpy bumps she has noticed anywhere in the body, like that. Then you have, whenever you are talking about the birth, immunization, nutrition, development, you have to take a short history about the development. Like, are you happy with the way your child is developing? So you ask that. After that, I mean, this is the basic layout of the red flags, but you open up, you do your hemodynamic stability, you reassure the parent, and then you go to the history of present illness. So the history of present illness in the case of seizure would be pre-ictal, ictal, and post-ictal. I'm not able to change the slides. Dr. Afshar, if you could please.
Dr. Afshar can move it up.
So these are the differentials that we have talked about. So a jerky episode can be anything. Now, for the questions before the episode, we have to ask any strange behavior before. That would give you the aura in the epilepsy cases or migraine cases. Now, second question would be, was he drowsy or alert before the episode? Any trauma to the head. So trauma is a red flag. Then any headache or vision problems, that would indicate brain tumor. Fever questions, infection questions, rashes. Then last meal. Why are we asking about last meal? Because we want to rule out hypoglycemia. Then vomiting, diarrhea, cough, and allergies, same, to rule out infections. Then you ask questions about what happened during the episode. So we want to make sure 2-3 things. We want to make sure the airway is patent. So we ask about any trouble breathing. Did the child turn blue? Was there any noisy breathing? Then we want to rule out any trauma during the episode, okay? So during the episode, did he fell down? Did he suffer any injury or blow on his head? Then you ask about how to differentiate the kind of seizure the child was having. So was it only one limb that was jerking, which would be a focal seizure? Or was it all the limbs that were jerking? So it would be a GTCS. Then, previous slide, please. Sorry. So after the episode, were there any post-ictal problems? Like I told that the child was unconscious for some time, but now he's fine. So you asked about weakness, numbness, headache. That would be to rule out focal neurological deficit. That would again, point to a head issue, head trauma or something like that.
Mhm.
So one question that is very nicely put here, was he able to walk in here? This covers all of them. Okay, so it rules out neurological deficit, rule out weakness, numbness. So you can just say that, is your child okay? Did he walk in here? So any question like that. So in the binds, what are you trying to see? In the binds, we are trying to ask about the precipitating factors for unprovoked seizures. For example, sleep deprivation, any stress in the family, any recent event that might have put the child under stress. If the child is going to childcare, any interaction with other children. If the child is in school, any bullying episode or something. Although
Okay.
these questions are more useful when you're taking a 6 minutes long history, in 4 minutes, you can only do this much, right? So, okay. Now, one important question that I wanted to hear was a family history. Family history, especially in cases of febrile seizures, because usually they are familiar. So with minds, just one little question: is any other member of the family has ever suffered from any such similar condition like that? So this concludes your history. You did a good job. You just need to organize it under certain headings so that in the exam, when you are under a lot of stress, you don't have to, what were the questions of infection? What were the questions of
Yeah.
seizure? What were the questions of brain tumor? So there are a typical set of questions for each condition which you should know by heart. Okay.
Okay.
Next slide,
Thank
please.
you. Thank you.
So now when you are at a diagnosis of unprovoked seizures, because you could not find anything in the history, so you will first of all reassure the mother that you are in safe hands now. You have come to the right place. You have come immediately, and that is good because we are not been able to find any loss. Okay, we have not been able to find any red flag, any nasty thing in the history, and let me reassure you that the child is safe. So now what I'm going to do, you have to tell it in very clear and precise steps. She's a layman. She wants to know what is going to happen next. So you have to tell it stepwise and very clearly that we are going to do some investigations to make sure there is no cause for these seizures. Because if there is a cause, that is treatable. Okay. So we are going to do some investigations, which would include some blood test, some urine test. Even if you say this much, it's fine. If you can elaborate, it's better. Like we are going to test the blood for the level of salts. She does not know what electrolytes are. We have to tell her that we are going to take the Mike's blood and we are going to test that for some salt levels, sugar levels, for some liver tests, some kidney tests, the urine for some problems that might have caused this, and then we'll be in a better position to say what is the diagnosis. Then I'll also refer the child to first seizure clinic. Now, these are certain terms which we call key points, okay, that you have to mention in each and every clinical case. So when you're taking history, the key points were the red flags. When you are explaining to the mother, when you're counseling the mother, the key points would be, first of all, some investigations. Second would be referral to a first seizure clinic because this is the first episode. Then you will have to explain her a action plan. Like, what if it happens again? What if it happens again? Then what are you supposed to do? Now it is your homework, Dr. Zara. You will go and search seizure action plan and you will tell me in later classes what it actually says.
Sure.
Okay. Then you are going to refer the child to a specialist. He might do some other investigations, for example, EEG, which reads out the brain activity and will be trying to image the brain as well to rule out any nasty growth inside the brain. So you just tell her, like, here we are going to do some tests. Then we'll send you to this clinic. There you will meet a neurologist and he'll do this. So that she has a plan in her head that this and this is going to happen. And now my child is stable. And then you will tell her all the 3-4 things that we always do. We review the situation, we explain her the red flags, and then we give her reading materials. This is how you close your case.
Thank you so much.
Okay. Dr. Tehreem, we'll just go 5 minutes. Has anybody got any questions or any further comments at this stage? Okay, I think Dr. Muhammad El Haddad would like to do, I'll just allow to talk. Dr. Muhammad El Haddad, you can talk now.
Hi, thank you, Rizwan, very much for unmuting me.
That's okay.
I just had a
I'm just trying to learn the ropes of this webinar thingy that I've just upgraded my subscription because I knew it's going to be more people than 100. That's why I sort of upgraded the subscription.
Congratulations on the upgrade. I also have never been on one of these subscription-based ones. So
Okay.
I think I had a question, Rizwan, to the previous presenter about that case. So the question is, how focused is the AMC clinical exam on the reality of the answer? Is it more focused on the communication of the situation, of your skills conversing with a parent, with a child, and recognizing the red flags, or
Yeah,
the
there are
content of your?
Yeah. So there are two components for essentially passing any AMC clinical scenario. There's a clinical component, and obviously there's a very overwhelming amount of communication aspect to deliver that clinical component or knowledge component. So the clinical component needs to be absolutely prim and proper. Where if it's a head injury, you need to demonstrate it to the examiner by virtue of your question, how you're classifying that head injury as mild, moderate, or severe. If you don't ask that question, it's not going to count. So you need to ask those questions. So no matter how heavy accented you are, how mildly accented you are, if you're not asking questions to highlight that, look, okay, did the child have a concussion episode? Did the child have any blood from the ears, nose, and throat, or any clear watery discharge? The examiner is never going to understand that how did you able to reach that conclusion that the child has got mild head injury and concussion without asking those essential questions. So that is pretty much going to be the knowledge aspect that you need to demonstrate by virtue of asking those questions. The communication aspect, as Dr. Afshan was saying as well, you need to sound simple when you're explaining everything back to the parent. And same, Dr. Kiran was, she's done a very brilliant approach of having a seizure aspect of assessment and management, assessing when taking the history and examination, but and management as to what she would be doing. So you can see that it's a perfect blend of both those things that you need to do. And you cannot emphasize, I have seen people with very good skills in English not passing the AMC clinical. So be under no doubt that just English is not enough to pass this exam. You need to have a core knowledge, and that too in such a rapid way within the time frame of 8 minutes that becomes almost like a challenge. I'll get Dr. Tahreem to start. Dr. Tahreem, can we finish in 10 minutes, please?
Yes, absolutely. I think I should run over this case.
Let's do that.
because-
Let's do that.
Yeah.
Let's do that. Yeah. Thanks.
All right. So hello, everybody. I'm Dr. Tahreem. I'll be taking the PM sessions with those who are opting for the PM group. Now, a good thing with these slides are, you can also see that how this course is approaching all the scenarios. If you have noticed the previous two cases and the one that has now come up onto your screens, you would see that somehow, somewhere, all of these cases are pediatric, and all of these cases are related to neurological aspect, something related to the head, something that can leave weakness in any part of the kid's body. So that is how we approach the case. With emergency focus, we are focusing on clusters rather than picking random cases from nowhere. We are trying to make a gist of the course by giving you a pattern to the exam by doing the case in clusters. This case over here is again of a little 8-month-old baby who now came to the emergency department. He had stopped breathing while he was feeding. He has been unresponsive for a minute, and now he's completely normal. His birth, development, everything has been normal. The only thing that was concerning was that he had stopped breathing, and now the mom has brought him to the ER. Now, because you have done 2 cases previously, which were related to the head, which were related to the seizures, that is the same approach you will bring over here. When you bring this approach, when you see such cases, the best way to do them is in your 2 minutes time, think about all the differentials, which were pretty similar to the differentials you did in the previous 2 cases, and then start on what happened before, what happened during, and what happened after the event which the patient and his mom has come in with. Can I get
Next
to?
slide. Yeah,
Yeah.
next slide. Dr. Afsha has got the control, I think. Yep, there we go.
Yeah.
Dr. Reem, I have given you the control.
Yeah, but it's not
Okay,
working.
fine. Okay,
Sometimes there's a bit of a lag.
yeah, sure.
Okay, so that is how you are going to approach this case. You are going to take a very good history. Again, empathy, sympathy, and your communication skills matter. And that is what we are going to help you out throughout the course, because it's not just developing knowledge. Everybody over here is a doctor. They have ample of knowledge. Now what we are teaching is how we are going to deliver that knowledge in a layman way to the mom and take out the relevant findings which you need to develop a diagnosis. So first of all, be very mindful of the person you're speaking to. If it's an examiner, you can go about with your medical jargon, but if it's a parent, you have to be very simple, use very simple language. So again, with this history as well, after forming some differentials in your head, you are going through the same thing. You are going to ask what happened during the event, how long did it last for, has something like that happened before, what did he change, so the kid stopped breathing, for how long did he stop breathing for, did he turn absolutely blue, was there any change to the tone of his body, was there any change to the state of consciousness he was in, did he completely became completely oblivious to the situation around him, were there any jerky movements, now you have to rule out the seizure that you already did in the previous case, were there any abnormal eye movements, did he lose his stools, or did he pass any wee when this happened, did he have any choking episode, did he have any gagging episodes. So you're going to ask whatever happened during the event. Then you also have to now go back to prior the event and think about what has happened before. So what was the kid doing? Was he sleeping? Was he feeding? Was there any vomiting? Was the episode related to feeding, which in this case it was? Has the child been recently sick? Were there any sick family members in the family? Was he eating something that could have choked him or had difficulty swallowing? Was the patient sleeping when this was happening? When if the patient was sleeping, what position was the baby sleeping in? Because again, SIDS is something which is very common in Australia. Then after you've covered the pre and the during, you go on and cover what happened after. So did the event resolve by itself? Was there any intervention, or was there anything the parent did to bring him back to his normal state? So you're basically asking, was there any CPR involved? And was the recovery then very rapid, or was it a gradual recovery and now the kid is fine? And do you think that there are any residual symptoms? So is the patient still having something from that event up till his consultation with the doctor? Then you do the basics. The basics of pediatric cases and approaching them is asking about his birth, which is very important over here. Was the patient born at term? Was he preterm? Was the labor induced? Then talking about his immunizations, his nutrition, and his development. And with his development, if he's 8 months old, just ask the most relevant milestone the kid attains at 8 months. So for an 8-month-old, the child should be at least standing with support or walking with support. So if the patient says no, then you go backwards and ask for other milestones to see if there is any developmental lag. Now, once everything of that sort is done, always ask about home situation. Non-accidental injuries is something that you should not absolutely miss over here, because these cases are some non-accidental injury cases are sometimes camouflaged in such a way that the parent would think there is absolutely nothing normal, when instead there will be lots of things which are also going on. So asking about home situation, asking about any stresses which are there in the family. Yeah, so that would be it. And then you will get an examination card for this particular case. Now I don't want Afshan to move the slide. Now think about this case in which the only finding that you got was that the patient had stopped breathing. He was less than a year old. Everything is back to normal. It lasted for less than a minute. Now, when the physical examination card comes up, absolutely everything is normal. Now, all your differentials about non-accidental injuries are gone. Gagging, laryngospasm, all are gone. Abdominal cause is gone. Everything is ruled out. And then what you're left with is something which, and again, there's no, we can't ask the kids, the candidates to participate, but the thing that is now left is something that we call BRUE. BRUE is BRUE. It is a brief resolved unexplained event. It is a diagnosis of exclusion. You can only say the diagnosis of BRUE when you have asked all the relevant questions. The examiner has noted that you have asked all the relevant questions to rule out all the other differential diagnoses, and then only you are going to say it's BRUE. So yes, it's a brief resolved unexplained event in which a child who should be less than 1 year of age has an episode of either change of color, change of tone, change of consciousness, and there's one more. Can anybody help me out?
And absent, decrease, irregular breathing, and cyanosis or pallor.
Yeah, so change of color, breathing, the thing that presented over here. So if there is anything from these four, there should be one, and it lasts for less than 1 minute, and the child is less than 1 year of age, and it is not explained by anything else. And the kid now is completely normal, then only you would say that this is a brief resolved unexplained event. It is a likely recall that comes in clinical exams. So it is also something that you should be doing. Now, recently, they have started the examination on a pattern of differential diagnosis. So keep your differential diagnosis in your mind with all the questions that you ask. You're going to rule everything out, and then your BRUE is going to come up. Now, if they ask you for management, you are going to see from your history that if it's a low risk BRUE or a high risk BRUE. A low risk BRUE is for a person for a baby who's less than 1 year old. He should have completed 32 weeks of gestation and then got delivered. When this event has happened, there should have been no intervention done like CPR. It should have been the first time, and it should have lasted for less than 1 minute. Now, if all of these things come up, you're just going to observe the patient. You're going to get a consultant, see him, but you are not going to do any active management, no bloods, no nothing, just reassurance, reading material, letting the patient know what BRUE is, let the patient's mom or dad know what the BRUE is, and then telling them the red flags, and then discharging them after a brief period of monitoring. However, if any of these things are not present, so if, or let's say if CPR was done, or this has been happening for multiple times, then it's not a low risk BRUE. Then it would be a high risk BRUE, and you are going to then keep them in the emergency period for long, more consultant reviews, more examinations and everything. And I'm just going to quickly give you a gist. Now, with this exam, the examiners just want you to know what a junior medical officer would do. They don't want you to treat the patient like a consultant. They want you to do what a junior medical officer would do in these scenarios. So whenever you are asking for things like a CT scan, always mention that you have to take into account a consultant review, because as a junior medical officer, you are not going to do anything. You're going to take consults. So yeah, that's pretty much it. The red flags that you will be telling the parents would be if he has, again, difficulty in breathing for less than a minute, if the child becomes lethargic, if he's not urinating, not eating well, drinking well, has proper generalized fits, come back to the emergency department.
Thank you, Dr. Tareem. I'll just quickly go through some questions before we end. So there's an anonymous attendee who's asked a very good question. Why pass rate is very low for this exam? If we present like this in exam, will we pass? So I think there are two questions. First of all, I'll answer the question which is more relevant. If we present like this in exam, will we pass? So right now, it's not the true depiction of what we do in course. Our course is more assessment based. So you come, we start the clock, you do the case, you get the feedback. journal, and you get the feedback specific, and we move on to the next case. So it's very exam oriented course, and obviously you build around the knowledge gaps in that way much more specifically. So this is what we've done, is very informal communication, introducing the tutors, introducing ourselves, so that you get a bit of an idea how you will be getting taught. But in the actual course, it's more bang, bang, bang. It's more timely, and people often feel quite overwhelmed in the first week that, oh, what's happening? Why the pass rate is very low for this exam? Look, I would not be able to answer you this question, why the pass rate is low. Obviously, with any exam, there are different pass rates for the fellowship exam, for licensing exam, and it all depends upon the quality of the candidates who are attempting this course. There's no published evidence-based result. It's all based on people saying that this is the percentage pass rate. If somebody's got a report of pass rate of being 20% or 30%, please share with me, and I'd like to understand that a bit better. But there's no published report on the pass rate. I think most of the time, historically, the AMC has been done by the people who have, who have primarily been out of medical practice for a long time, or they have also not been working currently in that sort of health system. So coming from a very different system, that could be the other reason. So there could be a number of different reasons. Communication aspect is certainly the key, and lacking those essential practical skills. So that is so crucial, that this is a exam which is based on your practical lingo, practical knowledge. So that's I think some of the factors why the pass rate of this exam is not as high as any other exam. But I can assure you, if all the people who are taking PLAB or USMLE, they suddenly shift and decide to do AMC, immediately the pass rate will go up. So you've got to understand, it's a cohort of people who take the exam. So that
can I just share my
Please.
I share just one thing? Now, why the exam pass rate is low? As for me, I've failed once and then passed it. And for me, my weak point was my preparation for the first attempt. My preparation was not up to par. The things that they require is like a robotic checklist. They want you to be very, very thorough with everything that you've said. And when you have said it, they are going to pass you. There's no turning back on that. So one, you need to be prepared. Number two is your circumstances. The circumstances, we are like 100 people over here, and there will be 100 different circumstances on the background against which we have to give the exam. Yeah. And then finally, it would be luck on the day. I've had friends who was even smarter than me. They eventually passed all the stations when they did, but they had failed the first attempt because on the day some tragedy had happened at their home, and then they had failed the exam. So it's a combination of three things: your preparation, your circumstances, and the luck factor as well of what actually happens on the day. So yes, don't take it like something that it's very simple and now it's like something that's from the university. This is something they want to be very, very sure that you will be 100% safe practitioner when you enter their medical workforce. And for that, they will not take any chances. So if you do a blunder, you do a critical error, they are going to fail you on the case.
That's good. So during one class, can I practice at least once with a tutor? Absolutely, yes. You will have plenty of chances to practice with a tutor.
Yeah.
Can you
go in circles?
Yeah,
so everybody gets a chance.
Exactly. Can you give a trial of the course for a day? This is the trial. This is exactly what we've done today. How many stations are there in AMC Clinical? What you can summarize here? There. Look,
I'm going to run all of that things in their initial classes as well. So yeah.
All right. All right. And I think that's about it, really. Any other questions? Quickly, I might be able to answer. May I check? You said taking a gap. You mean the break from the practice medicine, break from hospital-based medicine, from the general hospital? Yes, yes. So any kind of break from a clinical practice. Obviously, when you're not seeing patients or you're seeing patients in a different setting, you need to have to do a course to understand what's all about practicing over here. Can we practice enough with a teacher every week? Yes, you can. And plus, what we also encourage within our group is to make subgroups. And lots of our participants form subgroups, and we've got good numbers starting this. So you should be fine. All right. Okay. I think we'll end it here in the interest of the time. And let me see if there's any further. Saida, let's just allow talk. Dr. Saida,